Thank you for joining me. It's the HealthTree Foundation, not the Least Lymphoma Research Foundation. Sorry about that. I didn't catch that one as I was moving this title slide deck over, so I apologize, Dalton. But we're here with the HealthTree Foundation, obviously. Um, and so I'm Dr. Allen. I'm here in New York City at Weill Cornell, where I'm a specialist in lymphoma, but my research interest and my real true expertise is in the CLL space, where the vast majority of patients I see have CLL, and I run essentially most of our clinical trials. There's two of us that probably see 95% of the cases that come through Cornell's doors with CLL, and me and my colleague, Dr. Furman, see probably 95% of those cases. We recruited a recent junior physician as well, Dr. Mulvey. So us three are the team seeing CLL, and that's kind of my experience now. 11 years with our group here, and we've been pretty solid and stable. And it's a friendly experience with us, and I know that you'll get good care in our hands if you're out there and you're seeking help in the area. We can always obviously get you in for evaluation. But that's who I am. I know this is a nationwide thing, and there's a lot of great experts out there. And I was just tapped to do this discussion with you about BTK inhibitors. And so we'll have a high level overview of what are these drugs, how have they changed the world, basically. Why are they so important to our CLL patients, and kind of discuss some differences between these agents, as well as side effects and expectations. We'll talk about some of the other landscape as well, and kind of where the future might be moving towards in terms of combinations and so on and so forth that you might be hearing about or reading about. And we might even get approvals from the FDA later this year, potentially, where we might have doublets and triplets approved for patients, because currently right now we're doing them as single therapies with BTKs or BCL2, etc. So that's who I am, and we'll jump into our agenda. So we want to first talk about what is CLL, what is the epidemiology and pathogenesis. This is always important to understand who it is that's developing this disease, and how common is it. We'll look at prognostic testing. I think this is important for patients to understand and to ask their doctors about these things, because many times if you're not aware of this and it hasn't been tested, there is value to getting some of this information about prognostic testing, and the data would suggest it's not being done as often as we would like, and it will definitely impact how we follow you, and potentially in the very near future, what type of treatments we might offer as we get more and more data to identify best approaches. There are three big classes of drugs that are FDA approved. I'll really focus on BTKIs. PI3 kinases have been essentially relegated to very late lines of therapy nowadays. And then our one BCL2 inhibitor, venetoclax, but others are in development. But that's the only currently clinically available BCL2 inhibitor, and that's venetoclax. We'll talk about some long-term updates from CLL studies and some future landmark combinations, and how do we address resistance nowadays to some of these agents, even though most patients may not ever need more than one or two classes of these drugs if you have routine risk and you are being diagnosed in your 70s. You're probably going to need one class of drugs, honestly, and have a nice full life. So what does CLL look like? How do patients present? What is this disease? So the WHO has defined this, and CLL is rather easy to mark and stamp. Our pathologists, it's not a disease that can be very confusing or look or masquerade like other things, and it's actually relatively straightforward to diagnose. There's some nuance and some confusion around there with patients regarding the CLL versus SLL, and is that a different entity, and what is all that criteria? But essentially, CLL is a B-cell malignancy, a cancer. I like to kind of just call it a lymphoproliferative disorder, because that's in reality what it is, and it's a little bit softer on the ears and kind of represents it, I guess, in a better manner in that it's a very chronic disease, essentially, and the C word and the M word have much more of a heavier connotation, honestly. So it's a lymphoproliferative disorder, and it's a process of our B cells. B cells make antibodies in our body, and they are a major part of our immune system, obviously. And what CLL is where one of those B cells takes on some mutations and starts to diverge and become have a growth advantage. It doesn't die off like it should be. It's no longer being regulated in terms of how normal B cells are. And then it becomes this entity that we can identify in the blood. And the vast majority of patients present at a very early stage, completely asymptomatic. In fact, close to 60 to 65% of patients are picked up completely asymptomatic because they went to their doctor, their primary care, and did a CBC, and boom, it was a little elevated, or it persisted and remained elevated, or got a little higher than the last time. And many times when you look back, sometimes years, you actually see that the lymphocyte count was actually elevated prior to actually ever getting to the hematologist. And when it's subtle, many primary care docs can see this later. They say, oh, it was due to that recent infection or whatever. You can rationalize a lot of other potential reasons why there is this mild elevation. And it's not until it's kind of persistent and or starts to increase over time that some people get sent to the hematologist, but most are picked up within a couple of years, if not the first time they see this. And when you get to the hematologist, a very simple test, a blood test, all you need is blood to diagnose CLL. You don't need bone marrow biopsies. You don't always need lymph node biopsies because these cells typically are residing in the blood. And so when you send off that blood, it is a disease state that has a very certain specific set of markers that we test for. And basically, only CLL will present this specific combination of markers. And therefore, it's very straightforward to diagnose because literally that's the defining feature. There's no other disease state that expresses this combination of markers. And that is down there on the left bottom there. So it's a CD19 positive disorder, which tells you it's a B cell. CD20 is typically DIM. That is a target that we use anti-CD20 antibodies like rituximab or obinutuzumab for. CD22 is also a B cell activation marker that is typically dim in CLL. It's very bright in other disease states, and so that's one differentiating factor. And then CD5 and CD23, classically bright positive, and that's the defining combination feature. And then typically we look at this protein CD200, which is commonly bright and strongly positive on that feature. So this combination, slam dunk CLL, when you have greater than 5,000 of those clonal cells, your ALC can be 6,000. Your absolute lymphocyte count, or ALC, can be 6,000. But when you do the flow, you might only find 3,000. Well, that technically is not CLL because you need to have greater than 5,000 CLL cells to be diagnosed as CLL. When you don't have that and you don't have palpable lymph nodes, you get diagnosed as this precursor lesion called monoclonal B-cell lymphocytosis, or MBL. We think all CLL patients arose from an MBL state and progressed over time. That lead time could be a decade or even longer potentially. And we don't ever know it because the lymphocyte count is usually normal and there's no reason to even question it or send you to a hematologist, and we don't screen for this. So that's what MBL is, and it has some prognostic implications. MBL is catching something before it is something, and you can intuitively think that, oh, if I get caught at a very, very low, early stage, it's going to take even longer and longer before I might ever need treatment. And so many times our MBL patients diagnosed in their mid-70s are probably never going to even need treatment and may never even progress to actually meeting full diagnosis of CLL in their lifetime potentially. SLL is this nuanced diagnosis where it's small lymphocytic lymphoma. This is where if you look in the blood, you see normal blood counts. You don't have an elevated white blood cell count. Your hemoglobin, your platelets, they're all normal. And how these patients get diagnosed is typically they have a lymph node biopsy because they actually present with lymph nodes. And the lymph node gets biopsied, and in that lymph node are classic CLL cells. But when you look in the blood, they actually have less than 5,000 clonal CLL cells floating around in the blood. Almost all patients will have it, though. You can look and you can find it and you can characterize it, and it helps support that diagnosis. Now, the nuance between SLL and MBL is the fact that SLL patients actually have palpable lymph nodes or enlarged lymph nodes on a CT scan. If you don't have palpable lymph nodes or enlarged lymph nodes on a CT scan, and you've got relatively normal counts, and a count is less than 5,000 cells per microliter of blood, then you get diagnosed as this MBL state. So that's the difference between it. And in reality, about 15% of patients are diagnosed as SLL, but in reality, the diagnosis is CLL/SLL. We shouldn't get too caught up in saying, oh, I'm more of a CLL patient or an SLL patient, because the actual diagnosis is CLL/SLL. So it marries the two because, in fact, these cells are all the same. Biologically, they're the same. They have the same outcomes. They respond to the same treatments. The approvals are all the same, and it's encompassing these. So it can be hard for patients and sometimes primary care docs and surgeons and other doctors who aren't hematologists to kind of, is it leukemia? Is it a lymphoma? In reality, it behaves like an indolent lymphoma. We think of it like an indolent lymphoma or slow-growing lymphoma, even though the term leukemia is in the CLL diagnosis. In reality, it's basically a low-grade B-cell lymphoma of mature B cells. And our group, we're lymphoma doctors. The majority of the U.S. People who specialize in CLL are, in fact, lymphoma doctors, though there are specialized centers that CLL gets funneled into the leukemia doctors. And so, don't worry about that. It doesn't really matter. It's just where the expertise in that specific institution will put the CLL patients, because it does cross this spectrum of leukemia and lymphoma, because it does involve the blood almost in all patients, essentially. And that's where the leukemia part comes in. So the median age, when you look at the SEER database from this most recent year, the SEER database is how we kind of follow all malignancies, and they do have a specialized CLL tracking within the SEER database. And this is the most recent data. So the median age at diagnosis is almost 70, so 69. And depending on when you look at it, it sometimes goes to 70, comes back down to 69. CLL trends a little bit older than other lymphomas, which are usually in the lower 60s at the median age of diagnosis. But you can see well over 60+% of patients are 65 years or older when they are diagnosed, as you can see on the bar graph on the left. Importantly, we do see young patients with CLL, young being, less than 55. Very rarely are you, this is a disease of adults. We don't really see this in 18 or less year old. Can it happen? Has it happened? Sure, but typically they're not needing treatment, even if they're diagnosed, until they're in their 20s or 30s. And so, less than 10% of patients are diagnosed with CLL age 55 or younger. And so this is a disease state that trends older, and that's who we see it in. And that it presents a unique problem for those older patients because other comorbidities. It also presents a unique problem for younger patients because they have a long life expectancy. And how do we maximize all of these treatments and these great new drugs that we have, and make sure that we provide everybody whatever that normal life expectancy they had in their mind prior to any diagnosis, because we want patients to at least achieve that, if not exceed that. So on the right side, you can see the breakdown in terms of sex and race and ethnicity. About 2-to-1 male to female ratio, though, we see it in female patients, we see it in male patients, but it is about a 2-to-1 incidence. And you can see the non-Hispanic, white, Caucasian ethnic background have the highest rates I think this is per 100,000 or so patients incidence. But we do see this across all ethnic and racial backgrounds. though you do see less of it in specific type of ethnic and racial backgrounds. So there is something genetic that is driving this incidence. It's not completely well elucidated why certain ethnic backgrounds get CLL at a higher rates, but clearly it is related to genetics and predispositions to developing these B-cell lymphomas. You can see here the survival rate looks awesome and it continues to get better over time. And so that curve keeps going up. And this is a testament to the new drugs that we have, and we've eliminated chemotherapy from our regimens. We don't offer that in the US anymore. It's no longer standard of care. And so we see really great improvements and survival because of that, because of getting rid of chemo and because of we're using these non-toxic, well-tolerated treatments that have really improved survival comparatively. And this really, ibrutinib was approved in the frontline setting in 2016. So this is still, and it still took several years for the US and the world to even get behind using this drug as the frontline drug. And so, as we estimate out, beyond 2016 and forward, these 5-year survival rates are, frankly, they're pushing above 95%. So it's really changed the game, these drugs, and this is just positive news out there. And this is why, and I'll show you more data, why I truly believe our CLL patients are going to have normal life expectancies, and we've got data to support that. So the pathogenesis, I know there's probably some of you out there who might have some medical backgrounds or scientific backgrounds, others will not. This is not meant to try to overwhelm you, but it just kind of shows you how B cells develop and kind of where we think the mistakes start to happen. This is not an immature cell that causes mistakes. What happens is that the B cell born in the bone marrow matures normally, and it develops abnormalities in the periphery, in the lymph nodes, after it's been kind of mature, etc. There's a question, is there a CLL stem cell that continues to deviate? That's never been officially proven. And various ways along this path, very late in the B cell development, do we see the mutations and they develop into CLL. So this is a disease of a chronic, older, mature cell that takes on the abnormalities, not something that's really occurring in our bone marrow at a stem cell type level like other leukemias do. There's been well diagnosis of types of mutations that lead to development of CLL over time, and how that might impact and where, if you've seen chemo, what type of mutations might occur upon relapses, if you've just seen BTK inhibitors, etc. So this is just showing how this evolves over time, and the type of mutations and genetic makeup we see in your CLL actually is influenced by the previous treatments that you might have had. Richter's syndrome, this is something patients are always very concerned about. We are concerned about it. It is a disease where the CLL turns into more of an aggressive form of lymphoma and does need aggressive treatments like chemotherapy typically. Though with these new treatments, if you've never seen them, it's probably worthwhile to treat you with these new drugs, because there is this pseudo transformation that occurs that actually responds very well to these drugs. And so fortunately, only about 10% or less of patients in this day and age even transform. It's probably even lower now that we have these newer drugs. And in those patients, though, that do have this event occur, they are enriched in certain types of disease features. And if you don't typically harbor those, the likelihood of ever this happening to you in your lifetime is very unlikely and not going to occur. So what do you need to know? How do you establish your diagnosis? Well, flow cytometry is the standard of care. It's a very simple blood test. I talked to you about the immunophenotype that we look for. We try to eliminate mantle cell lymphoma, and that's very simple to do with this flow assay and some of these other tests. We then do FISH, or fluorescence in situ hybridization, and karyotyping. 80% of patients with CLL will have a FISH abnormality. And when you have a FISH abnormality, 60% will have a deletion of 13q, and that's the most common abnormality that we see. But each one of these abnormalities present can actually have a different prognostic implication. And so we have a panel because these recurrent abnormalities are present. Karyotyping is different. So FISH looks at the window. I'm in New York City, so I tell my patients about the skyline. And if you look at the Empire State Building from the sidewalk, FISH will show you a crack in a window on the 98th floor. Karyotyping, though, tells you what does the building itself look like. And so, and the example is, well, here in New York, if you're looking from where we are down south and you look at the Chrysler Building and the Empire State Building, karyotyping would show you that those two tops might have switched or they're upside down. So it's macro structures of the chromosomes. And we now know that a complex karyotype, or having three or more abnormalities in these macro structures of your chromosomes, is a higher risk feature and something we now test for routinely at diagnosis in our institution, as well as most others, honestly. It's not absolutely mandated by a lot of the guidelines, but most centers can do this, and it does add a little piece to the puzzle to help you understand risk going forward. The IGHV is another important assay to test for. There are two forms, either mutated or unmutated. You might be in chat rooms and you hear people talking about a mutated CLL. Well, this is what they're talking about basically, usually, is the antibody gene is mutated. And the normal process of a B cell is to be born in the bone marrow, set in your lymph node, wait for that lymph node, wait for that virus or bacteria that B cell is specific to. And when it does, it meets it and opens the DNA at that antibody gene and purposely starts to mutate it in hopes that the mutation results in a structural change of the protein or the antibody that binds better and more avidly to the virus or bacteria, at which point you eliminate the virus or bacteria. 7 to 10 days later, you get better. And the next year it tries to invade, you don't even get sick because you neutralize it because of this. This is called somatic hypermutation. We can tell if your CLL cell has gone through this process. And if it's mutated, that's a good thing. Paradoxically, ironically, that's a good thing because in this way, that CLL cell is maturing normally. It's developing normally. It's listening to the regulatory cues and not so rogue. The unmutated CLL form, which is about 50-50 down the middle at diagnosis, you never really know until you look, is a little bit more rogue and has shorter time to first treatments. Even though we use these new drugs, it's no longer relatively prognostically implicated, but can identify with earlier time to first treatments and more proliferative disease. And it is something that we want to understand and identify. The last component that we send off at diagnosis in my practice, as well as many other CLL specialist practice, is next generation sequencing. These panels have grown into hundreds of genes now. You rarely get 1 or 2 or 3 genes that you specifically look for. And we send these panels off, and these are other lymphoma genesis genes. And so out of these 300 or 400 things that we look at, only about 5 or so have been actually well independently validated at identifying high-risk disease. And so essentially, when we send these panels off, we look for those 5. Now, what's interesting is if I say I want to look for 1 and I only want the result of 1, they actually run the entire panel on every single patient, but they only report 1. And so, the information is there. We get information, we database build, we understand over time, oh, now this one is now showing up. This rare mutation might actually have some prognostic implications. So there is some benefit to getting a larger panel sometimes, but there is a lot of information we don't quite know what to do with. But it is nice to have a baseline of understanding what's going on and what gets acquired over time. So this is the NCCN guidelines. This is the recommendations for the workup, the prognostic workup prior to treatment and or at diagnosis. We do it at diagnosis, but you should have this all done prior to any treatment because it could potentially impact what type of treatment you might get, even in this day and age with these new drugs. So one thing that's important to note is that we have seen BTK inhibitors and ibrutinib is kind of now falling out of favor, but we're seeing chemotherapy be used less and less, which is a good thing as time goes on, as you can see here. But there is still about 15 to 20% of patients that continue to get chemotherapy. And if your physician is recommending that, really put them on the spot and say, why am I being recommended for bendamustine or FCR? Most are not doing that, but if you are in that scenario, definitely ask your physician, why are they recommending this? And it's important to note that while we are good, while we hope that all these patients have all of this testing, in fact, most patients are not getting this testing. So you can see the orange lines here on each one of these graphs are the testing is not performed. So 56, 70%, 61% of patients are not getting testing performed for FISH. 60+% are not getting it testing for del17P and IGHV as well. And then the thing is, and P53 is also infrequently performed. And one of the things that's important here is that when it is sent off and it is known to be mutated or deleted, there are some patients getting chemoimmunotherapy, which is absolutely not the right thing to do. So not only do we need to send the test more, but also we need to pay attention to the results and actually implement them in terms of management of care. And so that's why it's so important to have this information and ask your doctors about it, and to understand what's going on, and ask them why they have or haven't sent it. They may have reasons for it, and or they may have and may not have shared that with you. So the B cell receptor pathway is very important in CLL. This is kind of what the pathway looks like, and we take for granted of how all this works. But in reality, each one of these is a little tiny protein just floating around our cytoplasm and linking up because it has all these avidities and things turn on. And so it's basically chaos within a cell, and how it all comes together is always mind-boggling to me. But it is a beautiful thing of life, frankly, of how this has evolved. But nonetheless, this was all a black box from until 1993. So Dr. Bruton diagnosed the first children with XLA, X-linked agammaglobulinemia, in the 50s. But until the 90s, it was not known why children with XLA had that disease. And that's a disease where they don't develop B cells and they don't make antibodies and they die of infections at young age. In 1993, though, a discovery was made and BTK was identified. And before then, it was and when it was identified, the XLA children were tested to see, is this the disease is this the protein that's missing in those children causing the disease? And in fact, it was. And then once that was discovered, though, all of this was figured out. Before then, we knew antigens stimulated the B cell receptor, and we knew at the end of that, NF-kappa B activation, which led to proliferation and survival, and all these things occurred. All this stuff in between was completely unknown until the 90s, when from the 90s to early 2000, this was all deciphered and figured out. And then in 2005, the first inhibitors towards BTK occurred, and the rest is frankly history. So here's the therapeutic classes that we currently have available to us. You can see our BTK inhibitors are acalabrutinib, ibrutinib, and zanubrutinib, and we have our first non-covalent BTK inhibitor called pirtobrutinib, now currently FDA approved. We have one BCL2 inhibitor, venetoclax, and we have two antibodies, obinutuzumab and rituximab, that are commonly used. Right now, we do not have a standard, you are this type of patient with these disease features, you need to get this type of treatment. It is right now based on physician comfort, patient preferences, and people's belief of the data or understanding of the data of what might be the best approach for the patient. But we don't have good hard evidence that says one type of treatment over the other type of treatment will improve survival or something like that. We know all of these drugs are awesome, and they all essentially look equivalent. So the sequence of that you use these various agents, whether they're in combination or use one right after the other, has never borne out to matter, frankly. And those studies, some of the big studies, are still pending to maybe shed some light on this. But nonetheless, right now, it's a discussion between you and your physician on what approach do you want to use, looking at pros and cons of continuous treatment versus fixed duration approaches versus doublets and triplets. And we are getting gleaning that maybe maximal therapy and more triplet therapy might actually help some patients with higher risk disease features. But right now, nothing head to head. So here is kind of fancy graphs, and not that you need to understand this necessarily, but there's what's called a kinome screen. So one of the reasons in the US why we are moving away from ibrutinib, and it's not wrong to still be on ibrutinib or be recommended for ibrutinib. I still have patients on ibrutinib that are doing great and well, and they didn't want to switch after having discussions. But one of the reasons that we are switching is that we have learned over time there are BTK inhibitor class effects, and ibrutinib might have a little bit higher numbers of those. And what you see on the left here is the kinome screen. So when you inhibit BTK, what other enzymes do you inhibit? You can see with zanubrutinib and acalabrutinib and pirtobrutinib, you have a little bit less inhibition of other enzymes than ibrutinib, and therefore it's a cleaner, more selective drug, and that leads to potentially less side effects. On the right side, you see how well does the drug concentration stay in the body. And zanubrutinib looks great. It can stay above an inhibitory concentration throughout the dosing interval. Acala and ibrutinib shoot up and then they quickly come down, but these are covalently bound drugs. So you don't need the drug around, because the only way you can reestablish function of the protein is to resynthesize it, and that's not a simple, quick process. That takes 24 hours, and then you dose the next day, and any newly synthesized BTK you inhibit. Pirtobrutinib is unique in that it has a very long half-life and actually maintains a very high IC90. So when we're thinking about monotherapy BTK inhibitors, the current paradigm is daily dosing until progression. We typically use them as monotherapies, but they can be used with anti-CD20 antibodies and or even venetoclax, even though it's not currently FDA approved with venetoclax. It's in the NCCN guidelines. It's going to have approvals based on some of the studies that have been done, likely later this year, but we can currently do it. There's a lot of data. There's good safety data. There are great use cases to do it. And I do use these combinations many times for my patients. This class of drugs does have the longest follow-up. Now, we've treated patients well over 10 years and followed them for over 10 years on continuous therapy BTK inhibitors. It's very safe. We're not seeing bad things happen to patients, and it's dramatically improved survival. But it's one of these things that if you stop the drug, you will eventually start to progress again. That could be 6 months. That could be 2 or 3 or 4 years potentially after stopping. And so we typically think if you're tolerating it and there's no financial toxicity, no medical toxicity, then just stay on the drug and you might not ever progress or need another agent in your life. Safety is well defined. There are class effects. We'll talk about that. And it's been proven to be better than chemotherapy time and time again. And with venetoclax and plus or minus an antibody, you can really get very, very deep remissions. And we think you could be off treatment for up to a decade for some lower risk patients, if not longer. We don't think we can cure the disease, meaning you get a treatment and it never comes back. But we do think that, there are probably patients who get something in their mid 70s and have low risk disease. It's possible, they live their life without a recurrence or needing treatment again. Resistant mechanisms are now well defined, and fortunately only harm a subset of patients that are typically chemotherapy treated, but it can still happen if you have high risk disease features. Here are the kind of BTK inhibitor class effects that we look for. Atrial fibrillation, so an arrhythmia of the heart. Bruising and bleeding, we see this inhibit platelets like aspirin does. Hypertension has come out over time, so you need to be watching all of these things. Diarrhea is typically an early event that goes away on its own. Joint aches can be low grade but nuisance and actually cause dose reductions or discontinuations. And these are immunosuppressive drugs, so patients do get infections and pneumonias. We can see rashes, we can see fatigue. We see with ibrutinib, maybe less with these other drugs, but serious arrhythmias like ventricular arrhythmias. and then obviously cytopenias, thrombocytopenias, etc. Here's a schematic of how venetoclax works. It works very differently because it inhibits this protein BCL2, which is overexpressed in CLL, and it keeps the cell alive. It doesn't cause it to grow fast, it just keeps it alive. And so we inhibit BCL2 and it causes the cell to die. This I don't want to belabor too much. I think you'll get has access to all of these slides, but you do need intensive monitoring for this. But it doesn't have the bruising, bleeding, arrhythmia issues, joint aches. It's actually very well tolerated, aside from maybe low blood counts and possible some GI side effects at a little bit of a higher rate. But it allows for a very deep remission where we can't find the CLL in your blood or your bone marrow, and that allows us to stop treatment. And also it has approved outcomes. Here are the preferred regimens. This is the NCCN guidelines that guide your physicians on what they should do or what they can do, essentially, or how they should do it to try to uniform our management in the United States. So venetoclax-based approaches are just ven-oben or doublets and triplets with acalabrutinib or even other BTK inhibitors, though right now the only real data in a phase 3 study is with acalabrutinib. Though all have been studied together. And then we can see our BTK monotherapy approaches with acalabrutinib or plus or minus the antibody or zanubrutinib. But you can see it's been all these other things, which used to be the standards, are no longer the standards and are relegated. And frankly, just I don't believe should be used anymore in our CLL patients. So one of the advantages of combination treatment is to use the synergies between the drugs to improve the outcomes. And ibrutinib mobilizes the cells out of the lymph node, puts them into the peripheral blood. The venetoclax kills better in the peripheral blood than it does in the lymph nodes. And you can eliminate as many cells as possible and synergize that way. Here's just a finding of some of the big studies that we're waiting for. Amplify, which was this study here, the ACL 311 study, just reported at ASH last year. This is what's going to probably get the approval for acalabrutinib venetoclax or the triplet acalabrutinib venetoclax obinutuzumab potentially later this year. And then the CLL17, I hear we might hear about this at ASH, I'm told. Through the grapevine. I don't know if they submitted it or not, but this will be a very important study because this looks at ibrutinib monotherapy versus venetoclax obinutuzumab 1 year of treatment versus ibrutinib venetoclax 1 year of treatment. So important group there to follow going forward. And some of these other studies are going to be out there that will help us. So the benefits of the combos approaches is that it's an all oral treatment. You don't need the antibody, which we do know adds toxicity. Potential for very deep, durable responses after stopping treatment. MRD-directed therapy can actually maximize the response, and maybe we bring in the antibody for those people who didn't quite get there, but we mitigate how many people we need to expose to it. Unclear if maintenance helps or not, so we believe we can safely retreat patients when they progress 4, 5, 6, 7 years later. When you use a BTK inhibitor with venetoclax, you debulk and you don't have the tumor lysis problem, and it helps ramp up easier and safer. And by getting off of drug for short periods, the side effect profile essentially improves and goes away, and you don't have these long-term effects. Some of the questions that remain, though, about these combination approaches is fixed duration appropriate for all patients? Are there subsets of patients that should just continue on? I have my opinions on that, but without good data. What is the optimal sequence or combination partners? How do we maximize that? What do retreatment responses? We don't have a lot of data of patients getting a fixed duration and then being retreated. Many of these have only been approved since 2019 or later. And, these patients are still in their first remissions and only now, 6, 7 years later, are starting to require treatment again. And is there an optimal treatment based on those molecular prognostics? And how do you approach resistance if you've used some of the best 3 classes? Well, one that's very easy to answer is that you get patients off the drug and you don't expose them constantly. So the likelihood of resistance is very low. CAR T therapy is out there, and I do want to be able to answer questions for you guys. It's typically relegated because we got so many small drugs that are well tolerated, small molecule inhibitors, pills, so well tolerated that are seemingly as effective as CAR T cell therapy. The one caveat being is that their CAR T cell therapy for about 20% of patients could be potentially curative. We do start to throw that word around with CAR T cell therapy. BiTEs or bispecific T cell engagers like bispecific antibodies, epcoritamab, glofitamab, mosunetuzumab, these are all FDA approved in lymphomas. We are now starting to see them roll into the CLL space. And they have encouraging and exciting activity there. Again, some toxicities from the CRS and the immune inflammation that it can occur when you use these agents, and not quite their prime time yet, but hopefully we can have these classes of drugs. Then we have our reversible or non-covalent BTK inhibitors like pirtobrutinib, already FDA approved. It's going to get its full approval likely later this year based on the Bruin 321 study, which was a head-to-head randomized phase 3 study against idelalisib and rituximab. There's others in development, nimtabrutinib. So we have a lot of these drugs. These drugs were approved to overcome resistance to drugs like acalabrutinib and zanu. And so exciting there, and it gets patients controlled again and durable remissions and very easy, very safe, and very great drug to have and offer patients. We have other things, protein degraders, BTK degraders are now in the clinic and looking great. We have more selective BCL2 inhibitors, so maybe better, sorry for my typo there, better BCL2 inhibitors than venetoclax potentially, and others that are addressing resistance. So the research is great. It's exciting. We have access to some of these clinical trials currently that are open and enrolling. And, when the patients need them, it's nice to be able to reach for these things because they're still a few years away from probably being FDA approved. So to summarize, guidelines recommend a concise set of molecular assays to best treat our patients and prognosticate and predict the future. In general, testing is not being widely performed. And I think, our community practitioners are aware of this. They just they're not doing this day in and day out and sometimes forget. So there's room for improvement. Ask your physicians about them. We have three main classes of small molecules currently FDA approved, actually, and then the immunotherapies. We have BTK inhibitors and venetoclax-based treatments become standards of care. In the US, chemotherapy is no longer standard of care. And combo strategies are demonstrating significant activity. And how do we do this going forward remains to be seen, but is a nice option for a lot of patients. And resistance is possible, but new targets and drugs are coming around. And let's not forget, this is what I was speaking. This is long-term data of why I believe most, if not all, CLL patients will have a normal life expectancy. So this is ibrutinib data with 10 years of follow-up showing that those patients with CLL, age 65 years or older, getting ibrutinib in the frontline setting as their first treatment, now have the same survival as age-matched counterparts without CLL. And so that's not just age match greater than 65, it's all patients. And this has never been seen before in the history of CLL, where the CLL patients always had inferior survivals comparatively to their counterparts without CLL. And so now the survival is the same. You have to be on treatments, you have to control the disease, but we now have drugs and treatments that control the disease. And that's why it's so important to cancer screen and control the blood pressure, control the cholesterol, and diabetes. These things all might be bigger threats to our CLL patients than actual CLL in this day and age. So with that, I'll end and answer some questions in the last 10, 15 minutes here. Thank you.
Great. That was super informative, and I really liked that slide that you ended on there. I think it's really powerful to show that um, obviously CLL is not great, but that the survival is on pace with non-CLL people of the same age. So I think that's really encouraging to see. As Dr. Allen mentioned, now is our time for questions, so feel free to drop those questions in the chat. I also wanted to let everyone know that I will be staying on a little bit after this event if we want to get together and talk. I would love for us to come together as a community and just share some words of advice that we would give to someone who's newly diagnosed. So if you're interested in staying, I'll be doing that. But now let's hop into the questions. So we have our first question now that says, I was diagnosed at the age of 42 and started ibrutinib treatment 3 years ago at the age of 50. Ibrutinib has been well tolerated, but would venetoclax ibrutinib treatment offer a better prognosis than ibrutinib alone, considering a longer life expectancy?
Yeah, it's a question I can't necessarily answer definitively for you. With our younger patients, and I do, think of anyone basically less than 70, honestly, as young with this disease because you can tolerate these fixed duration approaches, frankly. And your lifestyle is important to be free of treatment sometimes. I like to offer fixed duration approaches for my patients, typically 75 years or younger, and depending on your fitness, obviously. So, in your 50s, being on ibrutinib and a BTK inhibitor, you heard me say that the paradigm is to continue treatment for that. Um, I think there is data to add in venetoclax to try to get you MRD negative, and all of the data would suggest that ibrutinib and venetoclax might actually be the best partner in terms of getting that. And younger patients, typically less than 60, don't have a lot of toxicities with ibrutinib. And so there is data to add in venetoclax to convert you to potentially an MRD negative state and get you negative and potentially off of treatment. But in terms of prognosis or survival, right now we've never proven that a doublet and a fixed duration and getting you in a deep, deep remission compared to just maintaining you with a continuous therapy BTK inhibitor leads to better outcomes. In fact, I truly believe no matter what we do or what sequence we offer, the survival and the outcome is going to be the same. So that is something to definitely talk with your physician about. There is data to support all of these things. If you are really saying, I don't want to be on drug for a long time, then it might be reasonable to discuss those options, but it still comes down to some of your risk features, et cetera. And not knowing the case, I can't always obviously extend a lot of personal opinions on it, aside from helping guide you to ask questions and know that it's appropriate to potentially try to add these things in and get off treatment if you're wanting to do that.
All right. That was a wonderful answer. Next up, we have an answer or a question about pneumonia and aspergillus in the lungs while taking zanubrutinib. Does this make you more susceptible for the same issues with the new BTK inhibitor, pirtobrutinib? Or would that be any different between these two, or would that be kind of a class effect?
Yeah, so immunosuppression is a class effect of these agents, and they all have typical interactions with treatments for aspergillus, which is azoles and the posaconozoles and the voriconazoles and the fluconazoles of the world. And so when you use these drugs and you have an infection like that and you're using antifungal agents, you do need to dose adjust the BTK inhibitor. You can still use them, but it's advised to dose adjust, and it depends on which azole that you might be using to treat while you're on these drugs. With that said, going to pirtobrutinib, I don't think necessarily is going to prevent or mitigate the risk of future development of infections. And obviously, CLL can disrupt the immune system and it doesn't easily heal. So this is something that once it starts to set in is a problem going forward, regardless of which of these drugs you use. But just by switching to Pirto doesn't necessarily mean that the infectious risk is going to be a little bit lower, though marginally and maybe numerically it might be shown to have slightly less infections. But it has the same problem with these azoles no matter which drug you are using.
Okay. And then next up, we have a question about neuropathy. This individual is on acalabrutinib for the last couple of months and has more recently started venetoclax. And they've got some tingling in their lower legs. Is there any relationship with this? And is there anything that can be done about neuropathy?
Yeah, so the neuropathies are not commonly seen with these drugs. These drugs are typically sparing our nerves and problems with our nerves. There are always cases where, patients will have some issue that's not very well explained or not well defined in the literature or the clinical trials or even in personal experience. And so it's important to know, what other problems might be in the spine and the lower back pain or sciatica, things like that, that needs to be ruled out. Sometimes if there's an IgM or if you have like a marginal zone lymphoma that masquerades like a CLL or whatever it is, sometimes these IgMs, and if there is a high IgM antibody being produced by the lymphoma, that can attack nerves, but it's unlikely to be caused by the drugs themselves. Neuropathies are difficult to reverse, and it's all about stabilizing them and preventing them from progressing. But speaking with your neurologist will be important. There are drugs like gabapentins and Lyricas of the world that play nice with these agents. You don't have to dose adjust or modify them very much, but it's not necessarily a fix. It just helps mitigate the symptoms, and definitely need to rule out other causes because it's not super commonly seen with these drugs as the direct cause of the neurotoxicity.
Okay. And then next up, we have a question about infection risk. So this individual has read that BTK inhibitors do not generally reduce infection rates in patients, and that serious infections still remain a major risk for mortality for CLL patients. Is there anything on the horizon to help deal with this issue, or any advice that you could give to patients that are really concerned about that infection risk?
Yeah, unfortunately, these drugs are all immunosuppressive. As the disease progresses, there will be an immunosuppression that is just from the disease without these drugs. The data would suggest that within the first 6 months, close to 30 to 40% of patients will have a higher grade infection, possibly even getting hospitalized. Usually it is URIs. Usually it's a pneumonia or bronchitis that you might need some antibiotics. Rarely are you ever hospitalized, and much more rarely are you ever kind of in a very serious scenario in an ICU and intubated or whatever it is from these infections. It needs to be monitored closely. There's no real prevention of that. It does affect most patients within the first 6 months, but as you get beyond that, there is some healing of the immune system, and the infection rates continue to kind of decrease over time. Uh, when you add in antibodies, that can increase the infection immunosuppression risk. Obviously, with COVID, it was a problem. It's maybe a little bit of less of a problem. COVID's a different animal nowadays in terms of its virulence, and we have treatments and so on and so forth. But one thing to look at is your IgG levels. If you are hypogamma and you are having recurrent infections, IVIG can help prevent that or help mitigate that. It doesn't prevent infections. But in the absence of low antibody levels, IgG or immunoglobulin G, there is no indication for IVIG. So that's something to discuss with your physician, because as your disease has progressed, it's possible that the antibody levels have decreased. And if there are recurrent infections, it is something to consider. But I don't start patients. It's IVIG is not so simple. It's a monthly thing. Once you start, you don't stop. It's got some side effects. And it can be an expensive treatment. So we don't we take it very seriously when we have to start somebody, and we don't really typically, just because we're starting these drugs, start you on IVIG.
Okay. And then this will probably be our last question just because of time. But so this individual was diagnosed 2 years ago, and they're still in watch and wait stage with blood work every 3 months. However, they've been reading about being proactive and palliative care, but they want to know, what does that actually mean?
Yeah. Hi. Hello. And I see the faces and the names, so I know some of you all out there. So this is an interesting question. You know, in terms of the palliative part of this, I don't know if I agree with that, and I don't know which article that you have read, because palliative has a very, specific connotation of we're going to focus less on treatment of the disease and focus more on symptoms. But being proactive is something I do agree with, and I think that's an evolving thing that we're talking about in our clinic and how I manage patients outside of clinical trials, etc. If I know that you've got higher risk disease, um, I'm a little bit looser to pull the trigger on starting treatment if I see disease activity. And so, the guidelines will suggest very strict cutoffs for hemoglobin and platelets. But if you see the white count rising and the platelets keep dipping down every time you're there, and you've got some high risk disease features, outside of a clinical trial, there's no wrong or harm in starting treatment. And if that's because eventually within a year you're going to be there, and we're talking about 30 years of a horizon here, starting treatment 1 year or 6 months a little bit earlier than you might have otherwise really matter in the big scheme of things. And I don't believe so. And if anything, it keeps the cliff edge as far away as possible and turns the wagons around before we ever get there. So I think in being proactive is the appropriate thing to do, to follow up in that 3 to 4 to 6 month range, depending on your molecular factors. Palliative, though, can have a lot of meetings, and obviously there are some symptoms that aren't so always easy to attribute to CLL. And sometimes, though, we are in a scenario where, weird skin rashes or other kind of fatigue and GI symptoms that shouldn't necessarily be to the CLL. We sometimes get pushed into corners where we don't know that it's not due to CLL, and sometimes we do initiate therapy there to see if it can help mitigate some of these symptoms. In my experience, though, many times there are not a lot of improvements in some of these things, aside from some of the kind of funny skin manifestations that can improve with treatment.
All right. Wonderful. Well, thank you for your time, Dr. Allen, and doing a great job answering all of those questions. We really appreciated having you today. So, I just thank you.
Of course.
All right. And again, as a reminder, I'm going to be staying on for a little bit to just chat with the community, but I wanted to let everyone know about a couple of upcoming educational events that we have. So on August 20th, so this will be next Wednesday, we have chair yoga for energy, strength, and serenity for those with blood cancer. This will be led by a multiple myeloma patient. So it should really be focused on the blood cancer patient experience and really how getting some activity can help benefit you. Then on September 2nd, we have exciting clinical trials for CLL in 2025. And this will be kind of highlighting some of the more exciting clinical trials for CLL patients going on right now. And then also on September 2nd, we have Staying Covered and Staying Covered, Navigating Insurance Changes When You're Living with Blood Cancer. So a lot of things on the horizon for the next couple of weeks. So be on the lookout for those. As a reminder, we do have the survey if you're going to leave this event. Please fill that out. It really does help us. And again, special thank you to AbbVie, our sponsor for today. And then just a final thank you to everyone for joining us today and really helping us grow our CLL community. Your support means so much to all of us. And big thank you to Dr. Allen again for taking time out of your busy schedule to come and present with us today. I've included my email on the slide here. Please feel free to reach out if you have any questions. I'm always happy to really be there and answer questions for the community. So anything you have, please feel free to reach out to me. I appreciate you all, and I hope you have a wonderful rest of your day. I'm going to go ahead and stop the recording in the live stream, and we can go ahead and get started in our more chat oriented part of this. So give me just 1 second for that.